one verse is visual.
Hello?
One account
Sir,
is
it's
logged out,
recorded.
ma'am.
Which account? Whose?
Nishant sir's.
No, both are there, no?
Nikita, I'm here. Both
Yes.
my iPad
Okay,
and
sir.
my screen both are.
Yeah. Start, Nishant.
Yes. So good evening, everyone. So this will be a short, quick class. Basically, we are covering up whatever we had missed out on the previous class. So we did complete up to how we are going to operate and what are the controversies during surgery in the last class. So in this class, we are talking about complications. So complications following.
Nishant, before you start, I think let us see if the students have done the homework. Yeah, Vinod, can you talk to us about the what is it called? Parotidectomy. What is it called? The
Adequate parotidectomy.
adequate parotidectomy.
Yes, sir. This is basically done for benign lesions. In this, we'll remove the lesion along with a border of normal tissue. It might be.
No, Vinod, you are wrong. You are wrong. Adequate parotidectomy is not for benign. Extracapsular is for benign. Adequate is for both benign and malignancy you can do. For deep lobe and superficial lobe as well.
Yes, sir.
What is the major difference? I had put it up also that day on the group.
Yes, sir. Even in this, the deep lobe will be involved, but in
what is the main difference between adequate parotidectomy versus extracapsular dissection?
Capsular dissections will be done only for the superficial lobe lesions, which but in adequate we can do even for the deep.
Main difference is in adequate parotidectomy you trace the facial nerve. In relation to facial nerve, you preserve the facial nerve and remove the tissue surrounding it with a sleeve of normal tissue.
Normal tissue. Yes.
Yeah. In extracapsular, you just you don't identify and separate the facial nerve separately. You just go around the lesion and remove it. So that is the main difference.
Yes, sir.
Okay. Right. Nishant, sorry.
No worries, no worries. So moving forward with the complications, two most common complications that we commonly come across in any surgery for that matter is hematoma and seroma. Of course, and we have told you how we are going to prevent this. That is by using a drain. Okay, the prevention is by trying to use a drain so that we get all the collection out. So that reduces the risk of post-operative collection, infection, and the healing tends to get faster. But what we are all, to be very honest, concerned about is the risk of facial nerve paralysis or facial nerve injury that we come across during surgery. Now, most of the times, if you are able to trace the nerve, the risk of permanent injury is rare. If you have traced and defined all the branches, then the risk of permanent injury is very rare. So whenever we talk about facial nerve paresis or complications, it is usually because of stretching or neuropraxia. And that is also called as the partial or the temporary facial nerve paresis or paralysis. And the incidence varies anywhere between 16% to 34%. And like I said, most of the times this is caused because of stretching of the nerve. When you're trying to define the facial nerve, when you stretch it across, or when you're trying to splay the nerves to get out the deep lobe. So these are scenarios where you can end up with situations where one particular branch of the facial nerve gets stretched. There is neuropraxia. So only in the post-op period, you'll see if only the lower lip is depressed. That means it is the marginal mandibular nerve that is damaged. So one segment of the facial nerve will be involved and very unlikely for the main trunk to be involved. Now, these injuries invariably tend to recover within 1 month. Almost 90% tend to recover within 1 month, but sometimes it can last for a longer period and they might take a longer period for the nerve to recover. And this can be as long as 18 months, that is 1.5 years. So you just have to patiently wait. Now, before we talk about treatment, now whatever I've mentioned under treatment is once you had a permanent injury. Now, my question to the postgraduate students. Immediately patient gets up from anesthesia. Let us say you've defined the nerves, you've done everything, you've closed it, but as soon as the patient gets out of the anesthesia, you'll see they're unable to close the eyelid or there is deviation of the angle of the mouth. What is it that you are going to do in terms of treatment? Vinod.
Sir, first of all, I'll check for any hematoma or seroma in the collection in the.
That is not there. No, it's already there. I'm telling you now there is neuropraxia that is already set in.
So we give steroids.
Steroids, sir.
Steroids. Can you tell me how these steroids function? How is it that the steroids actually help?
They actually do the anti-inflammatory action, sir, which reduces the further neuropraxia.
Okay. And where have you read that it actually helps?
Maybe
Okay.
in inflammatory condition because of neuropraxia, because of inflammation.
Yes. So ideally, steroids are to be used, let's say, in Bell's palsy, where there is inflammation, there is edema. Your steroids will help reduce the edema and will help the recovery. In surgery, it is not edema, it is stretching of the nerve. So even there is a bit surprising for me also. So there are various randomized control trials and all that have been performed, and they have checked placebo versus giving steroids for facial nerve neuropraxia that has happened during surgery because of stretching, and they found that those on placebo had a faster recovery as compared to those on steroids. So in short, steroids have no role because here the injury is because of praxia and not because of edema. Okay, so steroids have no role whenever you're dealing with neuropraxia in superficial parotidectomy. Second, in terms of recovery, if you are suspecting neuropraxia, do something called as physiotherapy. Okay, so physiotherapy where they force them to start exercising the muscles, where they have intraoral exercises where they massage the muscles, and these are something that can help fasten the recovery from neuropraxia. Next question. Now, patient is woken up from general anesthesia. Now, how do you know whether it is neuropraxia or nerve damage? And why am I asking this question?
Neuropraxia will heal itself, sir.
Correct.
In
Nerve damage will require intervention.
See, my point is, I told you most of them recover within 1 month. Now, you on post-op day 1, if you don't know whether it's neuropraxia or nerve damage, do you want to wait for 1 month? Or let us say, if it is a nerve damage, don't you think it is easiest to enter immediately on day 1 and do a primary nerve to nerve anastomosis or a nerve graft or something like that?
yes, sir. Early.
Correct?
Yes,
Yes
sir.
or no?
Yes,
Yes, sir.
Yeah. So how do you differentiate between the two?
Sir, in generally praxia's lower part of the face will be involved first.
What if I've damaged the lower part of the nerve? Let's say I've damaged the marginal mandibular nerve only. Okay. So here there are two concepts that we are going to look at, or two important points. One is onset of the paralysis. If it is delayed, that means immediate post anesthesia, they're okay, but gradually, let us say in about 24 hours or 48 hours, if they start developing weakness, then it is more likely to be praxia. Second is visualization on table. You have to depend upon your capacity or your judgment that you have identified. Be honest, be truthful to yourself. If you have identified all 5 branches and there is no cut in the nerve, at least the proximal or the main branches, then very, very unlikely that this is a nerve injury. It is more likely to be a neuropraxia where you just have to wait it out. Now, coming back to my scenario, my question, there is still a role of what we call as electron myography, okay, like EMG, where they can identify between neuropraxia and a nerve injury. Electromyography or electroneurography, both, I think it's a combination of both, ENOG, that is a short term that is used. So what they do is they use certain transcutaneous needles where they try and identify the nerve, and again another probe which goes onto the muscle, and they try to stimulate and see whether the transmission of impulses is happening. If the transmission of impulse is not happening, that means more likely that it is a cut injury or a proper injury where you have to go in and suture the nerve. And this is best done on post-op day 1. If you wait for 1 month, the adhesions are so bad that you will end up injuring more nerves when you're trying to get it. Okay. So, but this scenario, whatever I told you, more likely used in facial nerve trauma. Somebody has a trauma, now you don't know whether the trauma is neuropraxia or a cut injury. That is when this comes. Otherwise, most of the times it depends upon your judgment from what you have seen on table. Now, if by chance there is an injury, the most dangerous is any nerve which is affecting the eye. And can you tell me why? First years.
Oh, exposure keratitis, like causing permanent.
Excellent. So, idea is if you have, now I told you the patient is unable to close the eye. So, if the eye is constantly open, there is a risk of exposure keratitis. That is extremely dangerous. So, the idea is to either close the eye or keep it moist. Make sure no dust or a lot of air doesn't come into the eye and dry out the eye very fast. So, first is cover the eye, use some spectacles, covered glasses, lubrication with a lot of artificial teardrops, carboxymethyl cellulose, tarsorrhaphies where they kind of stitch up the upper and lower eyelid to reduce the aperture so that not much of air or dust gets into the eye. And you can also inject botulinum toxin there. Again, all these are techniques used to reduce the risk of exposure keratitis. Any doubts or questions in facial nerve paralysis before we go ahead?
Is there any role of giving neurobion or vitamin B12, all those things, sir, in praxia?
No, if it's praxia, it's praxia. It is just stretching. You just have to wait. The nerve will recover. Just wait.
Okay. Okay.
Can anyone say what Nishant has given the figures for probably partial or temporary paralysis? What is the incidence of permanent paralysis after parotid surgery?
Less than 5%.
Homework. Nishant,
I will give them
homework for them.
Yes, sir. Whenever we don't know the answer, at least from my side, I give it to you as homework.
Sir, and permanent injury, once we identify, should we go in and repair it as soon as possible, or
Yes, yes.
is it
Do
yeah,
it
okay,
immediately because adhesions, once they start developing. Now,
it
please
becomes-
remember earlier, at least you had a superficial parotid covering the facial nerve. Now there is nothing. So by the time you try to raise the flap, only most of the times you would have injured the nerve. So if you're going in, go in immediately. Otherwise, accept defeat, sit back. Don't try to do anything else. There's a chance if there is a single branch nerve injury, if you try to do anything, you'll end up causing injury to the main trunk of the facial nerve at that point of time.
Sir, post surgery, if a patient develops some symptoms of facial nerve, so we'll do every patient electromyography, sir?
No, no, no. That's what I'm saying. It depends upon the onset and what you have seen on table. On table, if you have seen all the nerves, you are very confident that this is a case of neuropraxia. Don't have to do anything, wait it out. This electromyography or electroneurography, whatever I'm talking to you about, majority of the times, the indication for this is for facial nerve trauma. Somebody sustained a trauma and come. Now you don't know whether it is because of neuropraxia or because of injury. Okay, but I'm saying that if you are in a dilemma, let us say patient is operated in in some other center and referred to you on day 1. Now you don't know what has happened. So that is when you are going to use this investigation modality. But if you are the surgeon, you have seen it on table, this is not a must. And if your center has the capacity to have this, you will also have the capacity to have a nerve stimulator on table where you would have identified it then and there rather than waiting till post-operative period.
Yes. What about steroids in RLN injuries?
Again, if it is neuropraxia, it is useless. That is what I'm trying to tell you.
Okay.
Idea is steroids is only for inflammatory pathologies, not for stretching. There is no role in neuropraxia.
Okay.
So now we move on to phrase syndrome. This is the most commonly asked question, pet favorite. So in short, I will tell you what happens. You're going to have your skin like this. Beneath the skin, you're going to have your sweat glands. Then there is your parotid gland. And there are parasympathetic nerves which come and supply the parotid gland. These parasympathetic nerves are secretomotor. That means they come and they stimulate your parotid and it makes the parotid secrete saliva. Now, post parotidectomy, parotid gland is no longer there. I've taken off the parotid gland and there is abnormal innervation of your sweat glands from these parasympathetic nerves. So now what happens every time a patient eats food, parasympathetic nervous system gets stimulated in order to secrete saliva. Now the problem is there is no parotid. Instead, it is stimulating the sweat glands of this particular area wherever the surgery is happened. So instead of saliva being produced inside the oral cavity, the patient starts sweating because sweat is being produced from the sweat glands. So the sweating is happening whenever the patient is eating food. That is why it is called as gustatory sweating. Okay, this is in short what exactly happens in Fraze syndrome. Now, the incidence they have quoted that in old papers it was as high as 50 to 100%. That means in almost every patient they used to see this. But nowadays, with the, I told you, we have to raise a thick flap. We've all learned from our mistakes. Again, here now they say the incidence is very rare. I really can't put a number. I tried to look for it, but there was no one particular incidence or the number that I could find. But they have said it is extremely rare. Okay, probably in single digits. So pathophysiology I've covered. Next, I want to know is the timing. This is, we'll ask Nikita and Praveen. Okay. When do you expect a patient to have Fraze syndrome after a parotid surgery?
So usually after the healing time, so approximately after 60 to 90 days, sir.
Praveen, any change in your answer?
Yes, sir, around 60 days, 2 months.
Yeah. So they say it's about 4 to 6 months. So please note that this is not a complication that you commonly see in the post-operative period. Okay, it will not happen immediately because these nerves and all need time to grow, right? They don't grow overnight. So if a neuropraxia can take 1.5 years, okay, where they're just stretching and for it to regain function. Here we're talking about nerves regenerating and going, so it will take a longer period. Just so it will take some time, like I said, 4 to 6 months. And just my thinking, that is also probably why the number of cases that are reported are less. If I have operated the patient and the patient is not happy with me and he has sweating, he might go to another patient. So thereby my incidence or the chance of me reporting becomes less because this is a complication that happens a very long time after surgery. And normally we don't tend to follow up patients for 4 to 6 months unless it is a chronic condition. If it's a superficial parotid I've sent the patient, I don't expect the patient to come back to me in 4 to 6 months. So that is probably another idea why it is rare. Now, how do you
Nishant,
diagnose? Yes, sir.
but that may be true in India, but in the rest of the world, most patients whom you have operated will come back to you. So they at least should have reported it. So
Yes,
on
sir.
that count, it may not be the
Yes, sir. But it has become rare because of the fact that we are raising a thick flap.
thicker flap. Yeah, that is probably the right answer.
Yes, sir. Now, first years, okay. How are you going to diagnose this case?
Before that, shall we ask them what is the you said of pathophysiology? What is the anatomy of the gustatory sweating or Frey syndrome?
Yes, sir.
So, so what is the nerve supply and which nerve supplies the parotid and through which it goes and all those things? Nikita,
Sir,
Praveen, you are about to answer.
sir, postganglionic parasympathetic nerve fibers of auricular temporal nerve, sir.
Correct.
Excellent answer. Okay. Now I will hold on to that, Praveen. I will ask you one question once we come on to treatment. Okay. Now, first years, Ainas and for Samir, if Samir is there. Okay. How do you diagnose a condition of Fraze syndrome?
So this starch iodine test that you do, you apply there is like you apply starch over that patch and it turns blue, sir. Like,
Can you tell me what exactly the starch iodine test is?
so that is like it's like stimulating the region, sir. Like you're applying starch in that region, just causing stimulation and.
Okay. In short, that is not the reality. Starch and iodine, if you mix it in a wet environment, it becomes blue. Okay. Remember, that's all. So idea is you apply starch, allow it to dry, apply iodine, allow it to dry, give that patient some secretagogue like a peppermints or a lime or something to suck on. Normally saliva gets secreted, but in this case I've told you instead of saliva, patient will start sweating. Sweat creates a moist environment where the starch and iodine will mix and which will give rise to a blue color. It's as simple as that. Okay, nothing complicated, just so that you guys understand how this happens. And if it turns blue, it is a positive starch iodine test. It's called as a Miner's starch iodine test. That is a prefix to this. Okay, so if that happens, it is more likely to be a Fraze syndrome. Now, please note that Fraze syndrome is best managed by preventing it. Okay, so probably that's not even the right terminology. The best is to prevent Fraze syndrome rather than trying to treat Fraze syndrome. Now, to prevent it, I told you one of the ways is to raise a thick flap. Okay, thick flap means it's between what two layers? This is what we discussed in anatomy. Vinod, thick flap means what is the anatomical layer in which you're going to go?
Between the fascia and the dermis, subcutaneous tissue.
There is subcutaneous tissue in the face.
I mean superficial.
SMA.
Yes. Okay, between the parotid fascia
Fascia
and the SMAs, the superficial musculo-aponeurotic system. Okay, so idea is if you raise a thick, that means at least the muscles of facial expression are there. So you know that you have a good thick chunk of tissue there. So the chance of this nerve going and reaching the sweat glands is lesser. So idea is have a thick flap, in short. Alternatives is to use acellular dermal matrix. So before you close, you can use these sheets which come, they are acellular dermal matrix. So the risk of cross reactions and all is very less. And most of the head and neck surgeons that I know prefer to use this. Okay, rather than only depend on thick flap, they prefer to use a acellular dermal matrix. Next one is autologous fat implantation.
Is this artificial acellular dermal matrix? Is it
Yes, sir.
artificial?
Yes,
Okay.
sir. Next is autologous fat implantation, where you take fat from another area and you inject it into this area in between the dissected area and your thick skin flap. Problem here is whenever you do this, you're taking fat from one area and putting it to the other. You're leaving a hollow cavity in the other area. So risk of hematoma, seroma, all that is there. Hematoma and seroma at the donor site. Okay, so if it can be, if you can replace the same thing by putting a acellular dermal matrix, so it is a, this is a described technique, but people don't prefer it because using an acellular dermal matrix is much easier as compared to removing or sucking fat. Basically try to do a sort of liposuction from one end and put it into your operated field. Next is something called as a SMAS flap. So there is skin and muscles of facial expression like this, and then your parotid gland and the parotid fascia. So what this SMAS flap is, so there is, so normally I told you this is the plane we are going to go in, but here what they do, there is two flaps. One flap is just beneath the dermis. Okay, here no subcutaneous tissue. Epidermis, dermis, raise it. identify the muscles of facial expression, raise that. So raising two flaps, okay? You're raising two flaps. One is the skin, next is your SMAS, and then you're reaching the parotid gland. You're going to finish the surgery. And then what they do, they pull this SMAS and stitch it over the mastoid. Okay, they cover that area and then again close the skin. Advantage what they say is when they pull this, it is like a facelift, like tummy tuck and all what they do, no, to pull. So the same way they say that the chance of seroma and all is less because you have pulled it and you have given it a good cosmetic appearance. It's as simple as that. Okay. So rather than having one thick flap, they made it into two layers, made sure there is gap between the two, pulled one layer and closed, and then closed the other layer on top. So that is what SMAS flap is. This is probably what you have commonly read in your textbooks, use of a temporoparietal facial flap. Now, please note, I've been telling you so far, it's about prevention. So if you have to do a temporoparietal flap, you have to extend your incision higher up. Only then will you get the fascia from there. So first of all, we're worried about cosmesis. So if you again have to extend the incision higher up, most of the patients might not accept if you tell them that I'm going to prevent a complication and you're trying to extend the incision. If you've had a complication and then extending the incision is a different scenario, but most patients might not agree to it. So the downside is increase in the length of incision. And of course, the last one is to use a sternocleidomastoid flap. Okay, if you have done a very extensive resection and there is no way or there's nothing there for you to cover that area, detach a little bit of the sternocleidomastoid and cover that area. Now, treatment. Once you have had Fraze syndrome, let us say 4 to 6 months, the patient has come back. First, try topical antiperspirants, but most of the patients felt that it didn't help them a lot. Injection of alcohol, okay, basically sort of neurolysis. You give put some alcohol there and try to kill off the nerve transmission. Injection of botulinum toxin. This is what is most commonly used. Now we're talking about treatment. We're not talking about prevention. It's already happened. Last option is surgery. Okay. In surgery, one, there is a flap. Second, there is neurectomy. Let's ask every registrars here. Between these two, which of it would you prefer? A flap or a neurectomy?
Flap, sir.
Flap. Anybody else? Sanya, flap or
Flap.
surgery? Flap or
Flap only, sir.
neurectomy?
Flap.
Okay. What flap are we talking about?
Temporoparietal facial flap, sir.
Now we are talking about treatment. We are talking about a surgery which you are planning 4 or 6 months later. There is no parotid gland covering the facial nerve. If you try to raise a flap to try and correct Fraze syndrome, there is a higher chance you'll end up injuring the facial nerve. Okay? Don't try to do that. It is extremely dangerous for the patient. Okay? It is a given option. I'm not saying no. But if we are struggling so much to identify facial nerve during a simple, straightforward parotidectomy, at least for us where the numbers are not that high, trying to correct Fraze syndrome, which is a very probably less morbid condition as compared to facial nerve, by raising this entire area again, going through that incision through a previously operated area with a lot of scar tissue, there is a high chance you will damage facial nerve. So please don't try and do this or don't attempt this as your first option. Instead, simple, do a neurectomy and kill off that nerve. That is much, much safer. Now, Praveen, coming to you. What is Jacobson's neurectomy? Which nerve are we targeting? It is not the auriculotemporal. Auriculotemporal is one of the types of neurectomy, but Jacobson's neurectomy is which nerve?
This is from tympanic plexus, sir. Basically,
sir.
From the inferior cervical nucleus, glossopharyngeal will carry. From the glossopharyngeal, there will be juxtapian nerve, which from the tympanic plexus, which will be a branch of glossopharyngeal. That nerve will be divided, which is going to the otic ganglion. From there, auriculotemporal nerve will carry.
Excellent answer, Vinod. So, in short, anywhere along that line, because parasympathetic is not just auriculotemporal, like how Praveen said. That is the last one. Okay, that's like the final stop. But before that, the tympanic nerve. Before that, you have the salivatory nucleus. Okay, so if you can target the tympanic nerve, which is probably more accessible, you can just go there and cut off the nerve or neuralysis or give it an injection of inject alcohol into it. That will also do the job. You don't have to identify the auriculotemporal nerve and hit it. That is also allowed. That is called as an auriculotemporal neurectomy. But the Jacobson's neurectomy is where we damage or where we kill off the tympanic nerve. So don't get confused in the exam saying, oh, auriculotemporal nerve is different, tympanic nerve is different, because the parasympathetic fibers run along various structures before they end in auriculotemporal nerve. Okay, auriculotemporal is the last stop. That's about it. Now, any idea what this first bite syndrome is? Registrars, first year, second years, third years, anyone? You guys are there or have I?
Sir.
Yeah. Go on, Vinod.
No, sir.
Samir, are you trying to answer? You just unmuted. Anyway, this is just for adding an extra point in your exam. So, see, a gland
Sympathetic,
has.
sir.
Pardon me?
Sympathetic going into the parotid.
No, I'll tell you. Okay. See, every gland has a sympathetic and a parasympathetic nervous supply, correct? Now
Yes.
we know that parasympathetic is responsible for the saliva secretion. The secretomotor fibers or the saliva secretion happens from the parasympathetic. Now, if by chance during your surgery there is involvement or there is damage to the sympathetic nerve fibers, you're only left with parasympathetic. Now, remember, sympathetic and parasympathetic are one against the other. So, if one takes the lead, the other one will try and pull it down. So, if parasympathetic becomes more, the sympathetic tries to neutralize it. Now, there is no neutralization from the sympathetic. So, the parasympathetic nervous system or the nerve fibers there become oversensitive and they tend to get overstimulated every time the patient eats food. All right. So, there is an extensive amount of parasympathetic stimulus that comes to whatever remaining gland is there, and the amount of saliva that is produced or pushed into the small acini or the ductules or whatever is there is so much that they're unable to handle it. So there is a sudden stretching of the ductules which gives rise to immense pain on the first bite as soon as the food goes in. And then gradually over the second and third bite, once that saliva drains out, the pain tends to settle down. And that is what is called as first bite syndrome. Okay. Just for knowledge that I just came across this, so it was a bit interesting. That's why I told you guys. Now, I spoke about seroma when in our first slide of complications. Now, what is a seroma that we're expecting there? It is nothing but saliva secretion. I'm not worried about simple fluid or post-operative fluid there. I'm more concerned about saliva being collected there, and that is called as sialocele. Now, homework for you guys. This incidence is actually there, but I want you guys to tell me. Okay, so in short, homework for you is incidence of everything that we have spoken so far. Incidence of Fraze syndrome, incidence of permanent facial nerve injury, incidence of a sialocele. Simple. All three, if you Google, you're going to get the answer. Now, sialocele is nothing but collection of saliva in your operated field. Now, the risk is it lifts off the skin, okay, from the underlying area. So there is a swelling. So cosmetically, it looks bad. Second, it is hampering the blood supply of the skin flap when it is getting stretched and when it's getting lifted off from the bed. So there is a chance of skin necrosis. So idea is to prevent a sialocele from happening. So of course, you're going to treat it like any other seroma. Aspiration and compression dressing. If you have not put in a drain and there is a collection, in a sterile way, clean, paint, drape, aspirate the saliva and put a dressing. Otherwise, sometimes even a hematoma or a seroma in that area, if it becomes very large, that can compress on the facial nerve and cause neuropraxia and what is that? Temporary facial nerve paralysis. So don't allow it to become very tense. Second is completion of surgery. That means you have done a superficial parotidectomy. No matter what you do, you are having recurrent psilocele. Go in and finish and do a total parotidectomy and come out if necessary. Okay, if necessary. That means remove of whatever little tissue is there. But in reality, I've told you re-entering and re-operating is like a tiger's country. So that should be chosen as the last option. Instead, you can try radiotherapy to that area to try and destroy whatever little amount of tissue is there. Local radiotherapy. Because if you have noticed in head and neck cancers, we give prophylactic radiotherapy, and these patients tend to develop Sjogren's syndrome, right? Dry mouth and all dry because the glands tend to shrivel up once they're exposed to radiotherapy. So you can give radiotherapy as well to try and reduce the amount of saliva being produced. And if you don't know the answer for anything in parotid, just write botulinum toxin. Invariably, you are correct. Okay. So that is another way of managing a psilocin. Last slide is on parotid abscess. First years, can you tell me what is Hilton's method? Samir and Anas. Are you guys there? Go on, Samir.
Sir, where major blood vessels and nerves will be there, we use the Hilton's method, sir.
What is it? What do you mean by Hilton's method? It's as simple as that. Okay, two things. One, use a blunt instrument. Second is dissection should be parallel to the underlying neurovascular structures. So in short, if there is a nerve like this, you should go in parallel. Don't go perpendicular to it and open because you might splay the nerve or cut the vessel or damage the vessel. Instead, if you are along the nerve, the chance of injuring it is much lesser. Now in parotid, we know that the facial nerve runs like this, correct? So ideally, the way you're going to open the parotid fascia should be in this direction. Your instrument should be opened in that direction. But the skin incision will remain perpendicular. That is why I've put this up. Otherwise, parotid abscess is not part of a chapter. But just to tell you guys, skin incision will be perpendicular to the nerve. Do not get confused. That is still your Blair's incision only because it is cosmetic. Once you raise your flaps, then when you're opening the parotid fascia or opening the abscess, that should be done in a perpendicular fashion to the skin incision or along the facial nerve so that you don't injure the facial nerve. Okay, so please note that one thing with respect to now Hilton's is not restricted to parotid. It is in general a technique where you avoid damage to a deeper structure. But for parotid, I told you skin incision is straight, but the fascia should be open perpendicular to the skin incision or along the course of the facial nerve. So that was the last slide that I had. If you guys have any doubts or questions, please put it up. If I know the answer, I will clear it or I will take the help from Ravi Shankar sir and Niranjan sir before I start taking inputs and more comments from them. Any doubts or questions? Okay, so no doubts means then Ravi Shankar sir, Niranjan sir, your comments and anything to add on regarding steroids in facial nerve neuropraxia. I just came across and I read it in a paper. That's the reason I brought it up.
Niranjan?
Nishant, I didn't get your question.
Role of steroids in managing neuropraxia after parotid surgeries.
I think it is controversial as when compared to recurrent laryngeal nerve injury, because as you already told, it's more of inflammatory edema in even if it is neuropaxia and thyroid, here it is more of due to stretching of fibers. So the probably there is a very limited role for steroids.
I think you're absolutely right. Only thing is it is given per chance it may help. So because there is nothing else to do, even if the recovery happens, it might have happened anyway. But so you per chance you give it, and because the dose is only for short period of time, no major adverse effects, they give it. That's what most people do. But I agree that it's probably not going to be very useful.
Just so that the
And
surgeon sleeps well.
yeah. Regarding the class, I think I learned a lot. I think there are a lot of very interesting points that you brought out, and you went into depth of the problem, and and made students understand that. I think it was very good. Thank you.
I agree with sir. Thank you.
Thank you, sir. Thank you so much, sir. So, guys, anything else, or can we wind up the class?
No questions, sir.
Done. So, sir, can we end the class, sir? Ravishankar, sir?
Yeah. Thank you.
Yes.
Good night.
Thank you, everybody. Good night. Have a good weekend, and we'll see you all soon.
So good night.
Thank you, sir.
Thank you, sir.
Thank you, sir.